if you're an age-friendly provider, what would you do in an age-friendly health setting? The age-friendly health system concept was a vision of the Hartford Foundation, the Institute for Healthcare Improvement, the American Hospital Association, and the Community Health Association. They recognized that ageism was a rampant problem in our society and in particular in the healthcare system. This related to the fact that the challenges of changing demographics were becoming more and more important as we thought about caring for more and more people who were older and more people who were older and fragile. We also recognize that the care and the needs of older adults are very complicated oftentimes. Their complexities relate to their physiologic changes, social changes, and emotional and mental health changes, all of which need to be taken into account when we're making decisions about their care. Healthcare systems aren't always prepared for managing older adults. As we all know, our healthcare system is really oriented towards acute care and not chronic care. How do we assure that older adults get the quality of care that they need? All of this led these visionaries to come together and put forward the age-friendly health system concept that you are now engaging in. The vision was to create a social movement where the care for older adults was really age-friendly, was friendly to them in the way that reflected their age and the changes that happen normally as a part of aging. The vision follows a set of evidence-based practices that are based in the science of care. What we do, how do we do it, and how do we make a difference, and how do we know what we're doing is the best approach. Obviously, the actions that we take should not cause any harm. That's something that goes for all of our patients, but sometimes we don't think about the things that we do with older adults may cause them harm. Example, giving up on someone saying, well, they're not really motivated to get physically stronger, so let's cut off their physical therapy and not cause them that discomfort. The important thing in this vision that we can't emphasize enough is aligning all that we do with what matters to the older adults and also to their informal caregivers. The age-friendly provider would see this picture and think, hoorah, what a wonderful depiction of the way in which we can be as we age. Obviously, someone who's having fun, someone who's enjoying life and has a great sense of humor. Behaviors of the age-friendly provider follow that essential set of evidence-based practices, causing no harm, and aligning with what matters. Think about what would happen if this provider was sitting in your waiting room acting up. What might your colleagues respond? How might they respond? What might they think about this example? Certainly, they're taking some assumptions about this person into account if they don't think about the individual and the older adult in a concrete way. Again, the 4M's. What matters? Medications, mentation, and mobility. We're always going to think about those and how do we carry these 4 principles out in our practices. First of all, it's critical that we abide by those concepts, that we use them actively, but also that we engage the entire team because a team is essential to addressing the 4M's. This builds on a module that you had previously that talks about interprofessional care. But interprofessionals, all professionals, need to have core competencies for the care of older adults. And that's what we're all about today. So who's on the team? And I know you've talked about this already, but it encompasses a wide number of providers. If you think back to the 4M's, it really becomes clear that the geriatric patient, or as we prefer to call them, the older adult, really needs all of these people, maybe not all at the same time, maybe at different times, but certainly can contribute to their health and their well-being, whether it's the social worker, the physical therapist, the occupational therapist, the pharmacist, the nurse practitioner, the PA. All of those folks have an integral role to play in the care of the older adult and must be part of an effective team. Take a minute now to think of a patient you've recently seen, now that we've talked about some of these things. Take a moment and think about how you could apply or did apply the 4M's in dealing with those patients. First, let's have a little brainstorm about what matters. How do we know what's important to the patient? How do we go about establishing what matters? It's very interesting when you think about it. How often do we say, "Why are you here?" Not asking for their symptoms, but asking what they want to accomplish from their time with us, whether that's in the hospital, whether that's in ambulatory care, whether that's in their homes, wherever that setting is. You want to begin always by asking what it is that you want. What does the patient want? What does that older adult want in their lives? So that we can align our care with their needs. Then we can do the appropriate assessments. Then we can think about how to talk with that patient. We can relate our treatment decisions not only to what they need, but also what they want. If you have a patient who does not wish or is struggling with being adherent to policies and recommended procedures and recommended interventions, and that person, one of their goals is they want to live to see their first grandchild born, you can work with them around how can you, and what can you do to assure that you will be around for that grandchild. So our treatment decisions and everything else we do really all must relate back to what matters. Medications. We need to think about medications a little bit differently when we talk about older adults in terms of what we do. The age-friendly approach means that you're going to use medications if they're needed, of course, but those that don't interfere with their mobility or their mentation. And I alluded to that a little bit earlier. So your assessments are going to be really important. If that person already has some of those struggles with their mentation or with their mobility, we want to be very careful about what medications we order and to work with the patient on making those decisions. How do you approach the patient? Be sure that they know the risks and the benefits of all of those interventions that we're thinking about. Make prescribing decisions that are appropriate for that patient, and don't be afraid to change them if they're not working for that patient. Obviously, patient and family teaching is a critical component of this particular aspect of the age-friendly paradigm. Mobility is incredibly important. If you think about what it would be like for you, it's important not only for people's physical abilities, but also for their mental health and for their social health. So we want to ensure that the patient not only has safe movement so they can get around without causing any damage, but we also want to be sure that they can maintain function and do what matters to them. So how does this approach change? Your assessments are essential. You really need to take the time to make careful assessments of the person's mobility, and then to make treatment decisions, recommendations, and referrals that relate to what that patient needs, what that patient wants, and to work with the patient to achieve the goals that they have for their own care. And finally, the concept of mentation means that we're going to prevent, we're going to identify and treat early, and manage problems that are common among older adults, as well as any other mental health problems that occur. Dementia, depression, and delirium, and some folks say anxiety, are really issues that we need to pay special attention to with our older adults, as they are common reactions to aging and to loss that takes place as we get older. So how does our approach change? Again, your assessments are really important. The way you approach your patient with some sensitivity, the treatment decisions that we make. Let me give you an example of how careful you need to be. And I'll tell you a story about something that I did. We were doing some surveys in the community related to food insecurity. And so we didn't want to we wanted people to fill it out on their own, but we didn't want them to be intimidated. The language in it was, I thought, a little bit complex, but we couldn't get it right down to the level. We also thought some people might have some language issues, and we had some translations. But there was one afternoon when I was the person, I was with students, so I probably wasn't a great role model, when there was a woman, and we got her age, and she said she was in her 90s, and I said, do you want to fill this out, or shall I read it to you and get your answers? And she gave me this withering look and said, just because I'm 90 whatever, it doesn't mean that I can't read and answer questions. So I apologized profusely. I wasn't making that assumption because she was 93, but she, in my approach to her, thought that I was saying something about her mental facilities and comprehension abilities. So the 4M's are not really a program, but it's a real shift in how we think about the care that we provide. All of these things are done together. It's not like this week is week to find out what motivates the patient, and next week is on mobility. All of these things happen at the same time in your environment. And there are methods that can be used to put this into your work environment that we'll be exploring with several of you who are students with us as we implement the 4M's across our partners as well as in our own care setting. The other thing about the 4M's is really built on what you already know. The things that we talked about today aren't rocket science. Everyone says we're supposed to do patient-centered care. I would suggest that we don't always do it well, and when it comes to the older adult, because of ageism, we even do it less well. The other thing, again, that's something that we know about, but we don't always do well, but becomes increasingly important with older adults, is that we have continuity of care plan. That we work with the patient, we work with the family, and we really devise a plan of care that's appropriate for that patient and that they agree to. The other thing, again, another thing that we always say we do, but it becomes increasingly important with our older adults, is documenting and sharing with the team. It really is important. I would suggest that one of the simple things we can do is not repeat everything we do in our practice. When the aide takes the blood pressure, the nurse comes in and takes the blood pressure, the physician comes in and takes the blood pressure, and then the PT takes the blood pressure. We probably don't need to do that unless we're doing some specific study. So think about the documentation, the sharing, and that will help us to reduce redundancies, repetition, and things that annoy me as a patient, and I'm sure annoy many of our older adults. So that documentation, that sharing is fundamental. The other thing is be a champion for age-friendly care, to speak up when someone expresses something that is ageist in its nature. Model for your colleagues how you can do age-friendly care and the continuity that you get, that you're really paying attention to those 4 modules very consistently and reliably. Now that you've completed this module, you're really well on the way to being an age-friendly provider and creating an age-friendly health practice and age-friendly healthcare system. So congratulations. Continue with us on our journey. Continue to participate in these modules and the other opportunities that we're providing, as it is about learning and learning how to change our attitudes and learning how to do what we do better. thank you very much for your attention. I look forward to working with all of you as we go on this journey together, and that we make the care of older adults in the community of Brooklyn an outstanding example for the rest of the nation. Here are some references that you may wish to look at, the ones that were used for this discussion. Again, I thank you, and that is the end of this module today.